Hello, everyone. Thank you for joining us today. My name is Filipina Sandoval, and I am the Training and Technical Assistance Manager here at NCHPH, the National Center for Health and Public Housing. Today, we're going to be talking about screening for public housing, community-specific safe sleep risks. And we have for today presenting Dr. Kevin Lombardi, and he is going to take it on from now.
Hi, everyone. Thanks for coming. Thanks for your service to health centers, for those of you who work for FQHRCs. And for those of you who are related to public housing, thank you for your service for that as well. My name is Dr. Kevin Lombardi. I'm a medical doctor and epidemiologist. I currently serve as manager of health research, policy, and advocacy at the National Center for Health and Public Housing. Today's session is going to be a lot of fun. It's a very important topic, and it's one of those topics where there's a lot we can do to make our patients' lives safer and to make their time with their babies as enjoyable and anxiety-free as possible. Today's session focuses on assessing and improving safe sleep practices in families. We'll be reviewing the material in a way that I believe will help anyone involved in pediatric primary care or health center management and preventative care, or those in social services or their social services related fields. The focus will be on the subject as it pertains to individuals living in houses, public housing, and specifically some of the other social groupings that are disproportionately represented within the public housing demographic and group in our country. Next slide, please. So before we start, a little bit about our organization, the National Center for Health and Public Housing. The mission of the National Center of Health and Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. Our organization is supported by the Health Resources and Services Administration and is a national training and technical assistant partner, and it's 100% financed by this grant. The information presented today is my opinion and my assessment. Next, please. So a little bit about the health centers who serve residents of public housing and HUD-assisted adults. Here we display data regarding residents of public housing and their enrollment as patients at FQHCs. Perhaps more than any other demographic class, residents of public housing rely on FQHCs to obtain their health care. It's a very important and disproportionate impact on their lives. A total of 108 FQHCs serve as public housing primary care centers. That covers about 900,000 patients in every U.S. state. Additionally, there are 458 FQHCs that are immediately accessible to residents of public housing, covering about 5.7 million patients. And my argument for everyone else is that residents of public housing and HUD-assisted adults live all over the country. So you most certainly have at least some of them at your organization and as on your patient rolls. And a better understanding of this class of people is a good way to serve your patients better and more appropriately. Next slide, please. So the demographics of residents of public housing are going to be particularly important for this subject, because a lot of the risks associated with certain groupings of individuals overlap. This makes residents of public housing uniquely susceptible to SIDS, and there are a variety of structural elements that create and perpetuate that we'll be looking over very closely. So, excuse me. These data describe the demographics of residents of public housing. As displayed, the 1.5 million residents demonstrate characteristics that differentiate them in a fair amount from the general U.S. population. For example, residents of public housing are approximately 2 times as likely to identify as being African American, 1.5 times as likely to identify as being Latinx, and they are 1.5 times as likely to be children as the general U.S. population. Residents of public housing also disproportionately come from households that are low income and female-headed, with 32% coming from female-headed households with children. This in particular will be the demographic that will be coming up quite a bit today. Next. So I have Fide here with me. She did our introduction for us, but the way we're teaching today, I'm going to try to make it as close to how I learned it when I was in medical school. So Fide is going to be engaging in sort of a talk back teaching session with me about it. Fide, I was wondering if you could quickly introduce yourself or in what you do here with us, and then tell us what you know about SIDS as just a general concept.
Yes, thank you so much, Kevin. So again, my name is Fide Pineda, and I am the Training Technical Assistance Manager here at the National Center for Health and Public Housing. And I have been here for the past 4 years, and it has definitely been a very rewarding experience for me as I am pursuing my master's in public health. And in the future, I'm very interested in this same topic, also topics that are related to maternal and child health and ACEs. So in terms of this topic, I believe that this is very important because this is basically something that can be prevented if the proper education is provided to the population of residents living in public housing. And I believe that definitely more information about it would be very helpful for all health centers to learn more about.
Okay, so do you know what SIDS refers to clinically? What the concept is?
Sure. So the concept basically refers to a sudden unexpected infant death. And basically that describes an unexpected death of children. So that is something that.
Yeah, so that's the basic concept here. And when we're talking about safe sleep, we're talking about SIDS. This is the primary bad outcome, and it's a major cause of infant death. And I mean, second, third, and fourth causes of infant death are SIDS or related conditions. So it's a very important issue. And your definition is correct. So sudden unexplained infant death and SIDS are two different things, but SUID is the one we are going to be talking about today as a broad concept. SIDS as well, but let's think of it as being a lecture on both of them. So it's a term used to describe any sudden and unexplained death, whether explained, unexplained during infancy, 0 to 4 months. It's a complex phenomenon. In case investigation, as in after an infant's death, it may be determined that an unexpected death was caused by a specific either natural or unnatural cause. Some of the most common are suffocation on blankets, on pillows, and so forth. Mechanical asphyxia, as in something imposing on the airway and stopping the infant from breathing. An object, or often when infants aren't on flat surfaces, contortion of the infant can raise the risk. Entrapment as well, but there are other non-physical causes such as infection, ingestions of specific foods or materials, metabolic diseases, and cardiac diseases. Trauma is also a known contributor as well. So when we're thinking of SIDS, I don't like to think of it as I think of a disease. I like to think of SIDS that it's an extremely complex, multifactorial phenomenon that involves all of these causes. It's a broad umbrella term. So just FYI, because of how SIDS is identified, it's identified after the fact. So there's limited good or reliable research indicating the relative proportion of the different causes of SIDS. The reason being is because an autopsy typically needs to be performed in order to make that conclusion. And autopsies are increasingly less common in the United States, particularly in pediatric patients. So we are limited in how we can talk about it. But unexplained sudden death in infancy SIDS is a subcategory of SUID. And it's designated to infant deaths that can't be explained after a thorough case investigation, including scene investigation. So it's a more conservative definition where we don't have the data. SIDS is the majority of cases, so it's what we tend to talk about. Next slide, please. And just FYI, everyone, the link to the full report on the bottom right, we will be sending the slides out with a post-evaluation survey, I believe. And each one of these has a different link to a study where it was taken from. For those of you who are interested in the topic or want to look more at sort of some of the emerging issues, give them a click and follow. There'll also be reports and screen tools later on that will be linked there. Epidemiology of safe sleep. So Fide, I show you this graph. I put this in front of you and tell you it's about safe sleep. What do you think, and what comes to mind?
Sure. So when I look at this graph, I can just see that the rate of combined sudden unexpected infant death rate is higher when you compare it to the other ones, to the other conditions, such as sudden infant death syndrome, unknown causes, and accidental suffocation and strangulation in bed.
What are you seeing with the trend line as it goes about from 1990 to around now?
Yeah, so when we look at the trends, it looks like it's decreasing since 1990 up to 2015.
Mm-hmm. So how about when we look over at 1990 all the way to the left here, I'm gonna grab the conversation from you, and your analysis is correct. From the perspective of the epidemiology and the policies and practices that have changed over the years, this is a very interesting graph, and it tells us a lot about what works and what doesn't work in preventing SIDS. So you'll notice if you look at the graph, what's the year where things are the highest?
Most definitely 1990.
And that's also the first year the graph is started, correct? The data is shown.
Yep.
When I look at this, the thing that really sticks out is that we have a period where things go down pretty significantly from 1990 to 1995-6. And then it continues to go down, but rather slowly. It's a kind of a plateau. There are some key actions that were taken throughout this time period that kind of show us what works and what doesn't. So in 1992, the recommendations to put babies on their back as opposed to on their bellies or on their side were first approved by the American Academy of Pediatrics. So pediatricians around the country were teaching this. And there was a uniform understanding amongst the medical community that this was what we were teaching patients. And what you'll see is after that, we see the numbers go down substantially. I'd say about 35% or more, and then they just kind of stay there. So what that tells me is that we've come across at least one very good policy that does work, but that we've reached some limitation in how much we're getting from it. And from analysis inside of the exam room, we've been able to see that there is space for us to improve how well we are communicating to patients, how their babies are sleeping and how they are sleeping with their babies and what they are exposing them to in a way that can really help lower these numbers even further. The interesting thing about that, Fide, and we'll get into the disparities very soon, is a lot of those disparities are more prevalent in residents of public housing, but they're also really low-hanging fruit. When we're talking about communication and education with FQHCs that are in or immediately accessible to residents of public housing, they're the experts at talking to residents of public housing. And improving the conversation is really where we need to go to be able to maintain and continue to improve with SIDS, but also to address some of the existing racial and ethnic disparities, which appear to be pretty low-hanging fruit when you consider what contributes to them. So each year in the United States, about 3,500 infants died of sleep-related infant deaths, including SIDS and SUIDS and all the conditions that are ICD codes underneath them. Again, umbrella conditions. After a substantial decline in the 1990s, we've seen this plateau. And this is because of recommendations, and the clinicians have followed through with recommendations. There are a variety of other factors that we're going to get into, though, that are different than just an issue of talking with people about how their babies sleep. Fide, considering some of the demographic differences between our population, public housing, and the rest of the U.S. population, are there any, and like considering the things that are related to those socially, economically, and so forth, what do you think about the risk of residents of public housing? Is it more or less, and why?
Oh, yes, for sure. So in my opinion, I believe that the risks are higher. A lot of it has to do with the racial disparities among minority populations that live in public housing. Also, these risks could also be attributed to the environments in which these residents live in, the exposures to various chemicals such as lead or smoke, or even being exposed to other factors that could lead to suicides.
And the data says something like that. So you went on through a couple of things that are actually addressed in my slides. This is non-practice, by the way, folks. We like to inject a little bit of creativity into our systems here. But you mentioned built environment and you mentioned smoke, and those are going to be two very important ones that are intimately connected to residents of public housing, but are also intimately connected to all patients that are experiencing an economic or social disparity, which is, and these are folks that show up at every health center. So next slide. Okay, so take a good look at this graph. And just to clarify the acronyms here, the column furthest to the left is American Indian and Alaskan Native. The next is, and these are U.S. Census categories, non-Hispanic Black. The one after that is non-Hispanic White. And after that, we have Hispanic and Asian Pacific Islander. And you can really see some of the disparity here when you look at those who identify on their census applications as non-Hispanic Black and those who identify as non-Hispanic White. You do see a significant disparity here. And that disparity has been well researched and well linked to a variety of economic and social factors. But when we're talking about social disparities and race, I want to be kind of clear about it with this issue, which is well studied and these disparities are well understood, relatively speaking. I want to be clear about the reasons. We have very good data on race in the United States. Race is measured here more probably than anywhere else in the world by possibly an order of magnitude. It's something we've measured very good historically and something we continue to prioritize in measuring. That's not a value statement about that, it's a statement of fact. Oftentimes race is a bigger piece of the picture in the data and analysis just because the data is better on it. But with this issue, there's also data that has indicated the primary contributors to this condition are overwhelmingly social. And have no causal connection to race outside of the social or economic sphere. So sudden unexplained infant death in race and ethnicity is a controversial topic, but it's important that we at least keep it in mind when we're seeing our patients, because it can inform us about the importance about relative topics and the importance of the conversations we have with the patients. And it tells us about how to understand and what questions to ask members of our community. We see the disparity, and considering these data in front of us, it's clear that rates of sleep-related death, like infant mortality, have notable and persistent racial and ethnic disparities. Cultural, behavioral, and economic factors all play a role here. In particular, difference in the prevalence of supine positioning as an infant's on their back, the recommended sleeping positioning, and other sleep environment conditions are likely main contributors to this. If we can go to the next slides, we can kind of talk more about the built environment and how that impacts our patients. Oh yeah, there we are. All right. Okay, so do you know about the recommendations about how babies should sleep, Fide?
Um, Unfortunately, no, I do not, but well, I would like to learn more about how that is.
Well, let's just say there's a variety of them. There's lots of them. I'll be going into them in a few slides. But one thing they all have in common is that they require on a certain amount of built environment. They require you to have a good, safe place to sleep. They require you to have the financing to get a nice bed for yourself, a separate bed, or a connected bed for a baby. And it requires you to keep the heat on at a certain level every night. Um, the What do you think the barriers could be there possibly for housing specific sleep risks for residents of public housing, given what we know about their economic situations?
Yeah, no, definitely. I think when you mentioned about having the rooms at a proper temperature, some of these buildings may not have the proper heating or proper air conditioning. That could be due to electrical issues or just the fact that maybe they don't have access to gas inside the buildings.
Mm-hmm. So yes, yes. These are all things that are disproportionately experienced, and I think the difference is exponential too. As folks have less and less economic support, these risk factors accumulate at an increasing and logarithmic level. So there's a lot. For folks that are have the least access to economic resources, they tend to sleep with their babies. At least that's my clinical experience, is they tend to sleep with their babies next to them because that's what works given their situation. That's a known risk. It's important to contextualize that in an appropriate way. This has always been a difficult subject for me in reflecting on racial disparities, because this is one of those places where you see where it affects the most vulnerable people on the planet. Those 0 to 4 months. So it can be difficult to not to understand it necessarily, but to critically look at how race impacts folks in this way. But it's a very important part to really understanding the issue and being able to impact appropriate change. With these issues that are related to the built environment, they're also fixable, right? They're expensive to fix, but they're fixable. And what I would recommend, if for folks who are at health centers that don't already have existing policies or resources, via social worker, community health workers, or pamphlets and so forth, that network folks to the resources that they may be able to apply for or get, that would help them get a safe place to sleep. Making that available should be a priority, or developing those protocols should be a priority. And for those of you who do have those systems, I'd recommend taking a look at them after this lecture and seeing if there are some areas that you might see as ripe for innovation. Another thing to note outside of the built environment and how it's related to cost is the importance of cigarette smoke as a main contributor. Any exposure to cigarette smoke in utero is connected to atrophy of certain areas of the brain during development. Those are certain areas of the brain that are related to our ability to breathe and regulate our breathing. You can look at animal studies and studies in infants to show that there is a linear connection between how much cigarette smoke you are connected to and exposed to as an infant, and what your risk is of SIDS. Not just by looking at the data of how often they experience SIDS, but by actually looking at their brains and seeing that there are fewer neurotransmitters, there are less thick areas of brain in development. This really and intimately connects impacts the development of a child in utero. So that kind of brings us back, 9 months beforehand to when we should start educating and screening patients about this, and making sure we're very cognizant of how much smoke exposure is happening at home. But smoke exposure isn't something that we always have 100% control over. If it's happening in the community a lot, mothers are being exposed to it. So it's in communities where there is a lot of cigarette smoking, it is an intrinsic and some very difficult to alter risk factor. And impacting policies that help to get folks in your community off of smoking. This is just one more reason to keep those in mind, is that it reduces this very unfortunate thing that is very modifiable, reduces the risk of it. Next, please. So to divert to understanding these implements that I've just given you, we've discussed genetic causes and social causes, environmental causes that we all think they have we think they have an impact. And this kind of gets to the cardinal issue with understanding SIDS, is that it's a very complicated phenomenon. And I like the triple risk model because it helps me to understand how these things contribute. And it looks at the different contributors to your risk of SIDS, and it shows kind of in a statistical and very clear way how these things can accumulate and conspire to raise the rates in certain areas disproportionately. So here I would like to go through some of the important biological factors that impact the development of SIDS. So developmental risks, when we're talking about that, we're talking about in utero. And the time directly before utero that would impact the mother's body. The pathophysiology of sleep-related deaths is multifactorial, and the most common intrinsic vulnerabilities recognized to date are the ones that are in the triple risk model. But to go over cigarette smoke is the first kind of major one. Any exposure is a risk. Any exposure. But within cigarette smoke, it's specifically the nicotine that impacts the development, because nicotine acts as it impacts the transmission of neurotransmitters. So anything that has nicotine in it, vape smoke, may also be a risk. There are no studies on this, but I would not expose a pregnant mother to any vape secondhand smoke as well, and prioritize vape secondhand smoke as a point of conversation in the exam room. Because we don't know how much it's impacting folks, and it might be a big impact. So cigarette smoke specifically impacts the areas of the brain that control your hypoxic drive, the things that tell you when you haven't breathed in a while, that you have high CO2 and that you need to breathe. These are like very deep evolutionary things in parts of our brain. And you and I as adults can think about our breathing, and we can strategize with our breathing, and we can use more conscious and active thought. Infants don't have that privilege. They are working on their hypoxic drive to breathe. And as a result, cigarette smoking specifically affects certain neurotransmitters in the brain during development, and raises your risk of hypoxic injury and hypoxia during infancy. So it's a big one, and just trying to get across that any exposure is risk, and it's a big risk. So prenatal exposure to tobacco smoke attenuates recovery from hypoxia in preterm infants. It decreases heart rate variability in preterm and term infants, and abolishes the normal relationship between heart rate and gestation at birth. Just to try to get across how extremely serious this is. To kind of bridge this over to substance misuse and alcohol as well, because there are connections there. Infants born to substance misusing, and smoking mothers have impaired ventilatory response to hypoxic challenges, and during quiet sleep and prone positions specifically. So what this tells us, the studies that have looked at this, is that when infants are sleeping in the positions that are approved and are the ones we want them to sleep in, and they've been exposed to cigarette smoke in the past, they are at higher risks of this condition. Cigarette smoke. There are also a variety of genetic and immunological risks as well. Some cases of unexplained infant death do have a genetic cause. The genetic causes and the reasons for them are very complicated and have a lot of terms that just aren't really relevant to like a public health perspective. But the important thing is there are certain genetic risk factors. They don't appear to be different among different ethnic groups in the United States. And they usually affect an infant's ability to respond to hypoxia, as in infant's ability to, when it's hypoxic and hasn't been breathing, to consciously say, oh no, I need to breathe. There are immunological risks as well. And these are an important one because something we hear a lot in the exam room is that people don't want to have their infants immunized because of the fear of SIDS. The reason for that is because there has been concern that the fevers associated with immunizations at times may raise risks of SIDS. There have been a couple of very large studies that have looked at this, 5,000 and 10,000 sample size, and with the hepatitis B vaccine in particular, and shown that there is no increased risk. The populations experience the exact same risk of SIDS as those who did and did not get their vaccines. So it's important in the exam room that we say this, though. Even for those who are still getting their vaccines, they may be thinking that this is a risk, or they may have suffered from getting that bad public health advice. Saying that in the exam room and making sure your clinical workers say this is very important. However, for those who have immunological conditions, especially those related to their innate immune system, they do have a higher risk of SIDS as well. Next slide, please. So anatomy of the safe sleep. I don't know how much you know about anatomy, Fide, but I'm going to ask you what you think about this. The one on the left is the recommended sleep position, and the one on the right is a sleep position that's commonly enacted but is not recommended. Looking at like the baby's internal organs, especially their trachea, what do you think about that?
Yeah, so by looking at this, I can just see that when the baby, the way that it is on the right side, it's more obstructed, like especially like the airway path, like from the mouth or the nose. It's definitely being obstructed. So I can see how that could impact this condition.
So some things to like from an airway management perspective. Looking at the infant on the right, what you'll see is one that when infants are on their bellies, their head is typically to the side, or in their airway is partially obstructed by either the surface of the bed, or potentially, if there's anything else in there, blankets, toys, and so forth. So you're already restricting airflow even before it gets into the body. Then when you look at just the curvature of the airway, and this doesn't quite do justice to what it actually looks like, but you'll have increased curvature of the airway. Increased curvature means that there's more air resistance, so it's harder for the baby to actually bring the air into its body. And the other thing is the weight distribution. When a baby is on its belly, there is more weight on the airway than when it is on its back. And more weight equals more airway obstruction or potential for airway obstruction. So these are the reasons why we tell people to do this. And they're really important ones. So when we look at if you remember the epidemiological data, how well connected this is to lowering the risk of SIDS. And this is a relatively easy thing to teach. And it's important to teach this in a way that's non-judgmental and comes naturally in conversation, but it's an important one nonetheless. So the official recommendations from the American Academy of Pediatrics is a recommendation of a sleep environment that maximizes reducing the reduction of risk. The most important of that is supine positioning or non-prone positioning. You'll hear it described as both. So the important thing is the use of a firm, non-inclined sleep surface. So we're talking about a flat surface. That's because surfaces that aren't flat can fold. And when you have a folding of that surface, you can have a folding of the airway further. And from what we talked, you might be able to kind of connect the dots and say, oh, that means more airway potential for airway obstruction. That means more potential for airway curvature. That means potentially more weight on the airway. It just makes everything worse. And that's one of the reasons why it's not good for infants to be on adult beds, is because adult beds often do not have the firmness that the infant beds do. Another thing that may be helpful in talking to your patients and saying, like, this is actually the specific reason. What I find is that recommendations are always taken with more of a smile if there's a conversation, an explanation behind them. So the surface is a big one, but Fide, remember when I was talking about this infant to the right here, and they were on their belly? What was the concern about before the air even got into the infant's mouth?
The concern before the air got
Yeah,
into the mouth?
what else could potentially block the air from going into the infant's mouth?
The pressure
Pressure. Anything there in the crib can do it, is the answer, actually. So a blanket, a pillow, a toy, anything can potentially go there and block the infant's breathing. Even on the infant on the left, the one that is sort of positioned per recommendations, a pillow, if you can imagine how big an infant's head is, a pillow or a blanket could very easily get moved in a way that obscures or bends the neck and raises the risk of SIDS. So if you follow this link, you can go to a report that has the full analysis of the recommendations, and it also has some cool little public health education documents that you may want to provide to your patients. Next one, please. Okay, so what I'm going to do now is go through the updated recommendations, the pertinent ones and the ones that have changed. So in 2022, so to go back a step more, in 2019 and 2020, there's data that indicated that SIDS deaths did increase a little bit. It's unclear exactly why. Sleep patterns may have been disturbed, or people may have not have been seeing pediatricians as often during the pandemic, but there was a spike. There was increased interest in the topic, and the American Academy of Pediatrics updated their recommendations after there were a variety of studies that looked at some things that weren't as clear previously. So I'm going to go through the big ones that are important and sort of emphasize why they're important. And then we're going to talk about some screening tools and how to have the conversation with patients in the exam room to make sure they know about the risk factors and what they can do to control them. So next slide, please. So the recommendations, these sorts of recommendations typically go level A, level B, level C, or level 1, number 2, or number 3. And the tiers are based on the levels of scientific evidence that we have. And there are a lot of level A recommendations for this one. This has been SIDS has been relatively well studied. And as a result, we have a lot of new data. So to one moment, I just need to plug in the computer here. There we go. Okay. So level A recommendations, and if you go to the link here, it brings you specifically to this table in a very nice printable list of the recommendations. If you've got a residents over there, or you've got community health workers or social workers, print one out and put it on a bulletin board, or hand them out. There's a good printable copy in there. So to go through some of the level A recommendations, some of these have been changed slightly. So things that have not changed is back sleep for every sleep. The use of a firm, flat, non-inclined sleep surface to reduce the risk of suffocation or wedging or entrapment, as we discussed. Feeding of human milk has been connected to reduced risk of SIDS. And it's recommended because of that. A controversial topic in the examination room for sure, but this is what the data tells us, and it is what the recommendations are. When you have patients that disagree with that, I think it's important, and you know that they disagree with that, I think it's still important to say it. So it's recommended that infants sleep in the parent's room, close to the parent's bed, but on a separate surface designed for infants, ideally for the first 6 months. So what is this describing? It's describing a crib, right? The issue that a lot of patients have, especially for those who aren't from this country or have separate cultural traditions, is that a lot of folks don't do that where they come from, and their parents and grandparents didn't do that. So there are systems to be able to accommodate people's cultural preferences. There are specific built types of cribs. Have you ever seen those things that extend off of the bed, sort of the co-sleepers? Those fulfill the recommendations. So when you're buying something, it's important to check to make sure they do. My understanding that everything that is approved and selling is, but I don't know that for sure. So that will have to be confirmed. But this recommendation has not changed, and it's a very important one. So other things, keeping soft objects, pillows, toys, blankets out of the sleeping area entirely is recommended as well. The implication of this that's important for those who come from difficult economic environments is one of the most expensive bills I have every month is how much I'm either heating or cooling my house, because it's either coming out of my gas or my electric bills. If I couldn't pay those, then I would limit my ability to control the inside temperature of my house almost immediately. So the problem with folks that don't have those resources, and this is disproportionately members of individuals who live in public housing, is they often do not have access to heating or reliable electricity or ability to pay their bills from month to month. And if the temperature in their house were to, because something was disconnected, suddenly drop or raise 10 degrees, that may not seem a lot like a lot for an adult, but it's a lot for an infant. If you look at their bodies, the amount of surface area to volume, how big their lungs are, the difference in how their blood vessels respond to heat, 10 degrees is very dangerous for an infant. And it could lead patients to do things to do things outside of recommendations, like putting lots of blankets or putting lots of pillows. And those are all very rational ways to respond to not having a way to keep your baby warm. But unfortunately, they also raise risk. Mm-hmm. That's why it's important to have a conversation when you're doing screening and you're talking about recommendations, because oftentimes there are very real reasons why folks have chosen to do something that may not be recommended. And you don't know that until you ask the question. If you know that answer, it may be able to give you the opportunity to network a patient to care, to network a patient to resources, to social services, a social worker, a community health worker that has the ability to network them is something that should be, a conversation that allows that to happen should be prioritized within the exam room. So other ones that may come as a surprise, offering a pacifier at nap time and bedtime is recommended to reduce the risk of SIDS. It's recommended that parents up until 6 months avoid alcohol and marijuana and opioids if they're sleeping with the infant. It's recommended that infants be immunized, and the recommendations are very clear to say that there is no connection between SIDS and vaccination. So something to consider with this, if the recommendation is that the baby is sleeping on its back all the time, every time, then the baby's not going to be spending very much time in the other position on its tummy. And that has some consequences in the development of the baby's musculature and the development of their body and ability to move. Because babies go from belly position to crawling, and then they advance to walking. So if a baby's never on their belly, they're not going to have the opportunity to work on those muscles and the brain development associated with the working of the muscles that gets them to the point where they're mobile. Because of this, tummy time is recommended, and like clinicians need to talk to their patients about this within the exam room. So in my experience, the tummy time recommendations are a tough one for parents because of the time it sometimes takes. Emphasis in the exam room of how important this is can help raise that up the priority level for parents, and is an important way of guiding them in a direction that will help them and their baby quite a bit. So down to the next slide, please. The level B C recommendations are not particularly important, so we'll breeze past that. But the link is available for those of you who are interested. Next, please. So screening tools. Screening tools. So Fide, when you think of a screening tool, why do you think we use these? Why do we even use screening tools? What do they mean for us?
Well, for the first thing that comes to my head would be, from a patient's perspective, is to assess their needs, but then also from a clinical perspective, as a physician, it would be to see what they can recommend to their patients.
Yeah, and so those are the two of the big ones. So we're trying to get data, right? This is an information collecting exercise. But I don't like to think of it like that. I think it limits our use of screening tools, and it limits our ability to impact change. The data does nothing if you don't use it. And where do you use data from a screening tool? Well, like if you're talking about preventing a condition, you use it in a conversation with the patient. So I like to reconceptualize them as conversation pieces. A screening tool is an important way. I like to think of it as the infrastructure to conversation. If you have a screening tool that you do yourself, or another provider does and gives you, it gives you the opportunity to look at that data and then to guide your conversation. Realistically, if I'm looking to have a conversation about SIDS, you remember how big that recommendation list was? It's not reasonable to expect someone to go through that in a 15-minute, 30-minute examination. It's just not possible to be able to do that, and all the other things that infants are experiencing, things that need to be done, that many of which are higher priority. So we put ourselves in a bit of a pinch, is that we don't have a huge budget of time to be able to educate patients directly. The screening tool, if I'm holding it as a clinician, allows me to look at it and focus on the areas that I need to talk about, and to focus my conversation. And since the patient has already done the screening tool, they've been talking about it. The screening tools, there are a variety of screening tools for SIDS. Compared to other conditions, the screening tools, in my opinion, aren't as good, and they're not as accessible because many are behind paywalls, or their evaluation metrics, the screening, like how you sum up the numbers at the end, isn't totally clear or easy to use. The BISQR is the best that I have found, and it's the best I've used. But I'm not saying that there aren't things out there that I haven't seen. And for those of you who do see these patients, if you have something that's better and you have a reason why, please let me know. I'd love to know. But I find this screening tool helpful because I think it can be integrated very well into workflow as well. The important thing about a screening tool is that it's a part of a conversation, and specifically one that has the potential to change behavior. So my recommendation is that you conceptualize the screening tool is the ways the clinician use these within their clinical discretion as a way of targeting conversation, as making it efficient and direct. However, having sometimes the screening tools do need to be integrated into the workflow. My recommendation for the use of SIDS screening tools and the BISQR is, one, take a look at your facility recommendations and see if there's anything existing in use, what's being used, and what your facility rules are with the use of screening tools, if there are any. And that's important because these can be very effectively put into workflow with community health workers or social workers at certain parts of the workflow. And I mean the ones that are downstream from the clinician. Where it goes and where the most appropriate place to put the screening tool is needs to keep that in mind, but you also need to keep in mind what your workflow is. So my recommendation is that it's directly downflow from the clinician if the clinician cannot do it themselves, and that of course sole discretion on its interpretation is within the hands of the clinician. It's a very simple and relatively simple screening tool. And it has been studied in situations where non-physician providers are the ones giving it, and they can reliably give it. So if you can integrate it outside into your workflow and save your clinician time while still giving them the ability to talk about this appropriately, I would recommend having a conversation about that at your facility. So even if your facility does have something that they're using, the 2022 guidelines have changed how we are talking about this, and some of the public health guidance. So for those of you who do know of institutional policies around the prevention of SIDS, or specifically about SIDS, or if you have existing collaborations or partnerships and organizations to reduce SIDS, and you haven't since 2022 taken a look at the fine print of your agreements of the things that are being taught or the things that are the materials that you're giving to patients. Now's a good time to take a look at that to make sure you're capturing everything the American Academy of Pediatrics recommends that we prioritize. Moving on, next slide, please. So I'm going to give a few minutes for questions here, but just to briefly go over our contact. I'm second from the top here. Fide is second from the top on the bottom. Look, we're neighbors. Feel free to contact us for any questions about this lecture, any of the material, or if you have any comments or concerns, I would love to hear them, or insight of more materials that could be integrated or exciting things in the field. Please don't be shy. If you work at a FQHC in a position that is connected to management or leadership, the National Center for Health and Public Housing does offer free consulting services to you, and I'm the one that does that. So if you'd like to give us an email for any questions related to health center management, transitions in the time of the end of the public health emergency, or chiefly my expertise is in methodology of evaluation of programs within FQHCs. And I would be happy to do your analysis or consult you through your analysis and provide some legwork as well. This is a free service for FQHCs, so please reach out to us. We'd love to hear from you. I guess we'll open anything to questions or concerns that folks would like to pop in. No pressure, but for the last 5 minutes, we will stay here and do that.
And just a reminder, if you're also more than welcome to submit your questions or any comments or any promising practices in the chat as well.
Okay, super. Well, I am going to stay on for the remainder of 3 minutes, remainder of the 6 minutes left. For those of you who don't have any questions or need to go, you can go ahead and we will end the lecture soon. Thank you. Hey, Fide, if you could stay on, please.
Mm-hmm.
That's okay.
You're welcome.
Oh, and thank you all to your service to your patients, by the way.
Also, before I forget, there is a post-evaluation survey. We would be very happy to see your responses. Please provide your feedback to us and let us know anything that we can do to improve, or what you liked also from the presentation today. And that post-evaluation survey is going to pop up on your screen right after you sign out from the Zoom meeting.
All right, PD, I think we're good as far as questions. I'm going to jump off. I'm going to.
Yep, thank you. Goodbye.